pressure flow and the cardiac and vascular function curves. So for the resistance and pressure flow, we have the equations. The flow rate, it's the represented by Q, and it equals for the flow velocity by the cross-sectional area. For the resistance, it's basically a change in the pressure, so it's fluid moving from an area with the highest pressure to the area with the lowest pressure, and that's the normal over Q, that is the flow rate. So what we have is like we probably studied this in physics, is that like two ways to calculate the resistance. If there is a resistance following a resistance in a serial manner, like in series, so the total resistance of all the resistances over here is just R1 plus R2 plus R3. While there is something different, that's when so basically let's talk about this in series first. So if this is a blood flow coming into this long huge vessel, and it's just going only in one direction, and it's passing each resistance and then following to the next one and then following to the third one. So this is the series connection of the resistances. So a resistance, basically what we mean here is an area where there are like capillaries, capillary vessels, like whether they're arterioles connecting with venules, and here we have an area of oxygen exchange, of nutrients exchange, and everything in the tissues. So if we want to know the whole resistance, that the total resistance that is resisting this blood flow into this direction, that we're going to just simply say that the resistance that we get in the tissue 1 plus the resistance in tissue 2, or the resistance 3, because they're just in series. The other condition that we have, if we have a blood flow coming this way, but it's dividing into different places, so it's going through all the resistances at once, it's going to resistance 1, which is in parallel to the resistance 2, parallel to resistance 3, and then the blood is collecting and going back through the vein, let's say. So basically what is happening here is that whenever we want to collect the whole resistance over here, the resistance that is just resisting this blood flow going into it, is not going to be simply just like in series R1 plus R2 plus R3. It should be different. So it's now the 1 over the total resistance equals to 1 over each one of those resistances, because this connection is in parallel. And now if we take a look at the image over here, is that most of the body parts are attached to each other in parallel, because like basically this is the head, this is, I don't know, the neck, and oh my god, this is the trunk, upper limbs, and then lower limbs, and then that's it. So each one of those is getting its own blood supply through the part of the main vessel, that is the aorta. So the aorta is just going to all of these at once, and this resistance, the resistance of the capillaries in the head, is in parallel to the capillaries in the arms, which is also in parallel to the lungs and everything else over here. So that's why all basically the resistance between organs of the body or parts of the body, they're in parallel, as we can see. But for example, we have, let's use the blue color over here. This is the GI circulation. So for the GI on its own, we know that the venous blood supply that is going out of the GI tract is going to form the hepatic circulation in the liver. And now we can see like there is resistance 1 in the GI, and there's resistance 2 in the liver, but they are in series, not like in parallel. So let's say for the GIT system on its own, not compared to other resistances in the body, on its own, it has like 2 resistances over here. So this is called parallel. This is what's called in series. Now, if we talk about this, it says like capillaries have the highest total cross-sectional area, and it makes sense because the capillaries, even though they're small, but they're like too many. So if you just spread them, they would make a total cross-sectional area that is way too high and considered the highest in the body. And also it has, because they're small, so they're kind of don't allow a lot of blood going into it, so they have the lowest flow rate. For the pressure gradient, it drives, as we said, a flow from the high pressure to the low pressure. For the arterioles, they account for the most of total peripheral resistance. So we're going to talk about this a lot. It's the total peripheral resistance. It's where the arterioles, like they are the smallest part of the arteries, and this is the part that is giving its oxygen and nutrients into the tissues. So the arteriole walls do have some vascular smooth muscles. So basically, they are the best indicator, or the factor that affects the most of the total peripheral resistance. So whenever we're talking about total peripheral resistance, we're talking about its major factor or major effector, and that is the arterioles. So for the veins, they do have some kind of a function. It could function as a blood storage, because they have the ability to contain more blood. So they can have more blood within them, so acting as storage. The viscosity depends on mostly on hematocrit. So viscosity is how thick or the thin that fluid is. So in case of a blood, it depends mainly on how much hematocrit is in there. So the viscosity, of course, increases in cases like hyperproteinemic states, because the blood contains now too many proteins, so it's not as thin. So that happens in multiple myeloma. Now I have higher viscosity. And also in polycythemia, because we have too many RBCs. So that's why the viscosity increases. But in other cases, we have the viscosity decreases, as in anemia, because we have lower blood cells. So it doesn't have a lot of contents for the viscosity. So that's for the resistance and pressure flow. Now we're moving to the other part of the page. So for these function curves, we have three main variables. If we take a look at this graph first, let's understand like the basic points that are needed to understand all of these graphs. So basically what we have here is the x-axis, and here is the y-axis. So this graph is just showing us what we have. I mean, how can we compare the x-axis regarding the y-axis? The x-axis is the right atrial pressure, and it kind of equals to the end diastolic volume. So if we draw a heart over here, okay, let's make it smaller. So this is a heart, and here is the right. Actually, this is the left atrium. This is the left ventricle, this is the right atrium, and this is the right ventricle. So what we have here is that the right atrium is the place that gets the blood from the systemic circulation through main vein, that is the superior vena cava, and then from here is the inferior vena cava. So all the blood in the body is just going into the right atrium through these veins. So this vein, the blood that is coming through these veins is called the venous return. So this blood is just going to the heart, going back to the heart. That's why it's called venous return. It's through these two major veins, superior vena cava and inferior vena cava. So what we have here says that here is the right atrial pressure. The right atrial pressure is kind of equals to the venous return. So now the venous return is going into the right atrium, and the pressure within it and the blood within it is going by time to move forward to the right ventricle, right? So it's somehow going to fill the right ventricle. So when does it fill the right ventricle? When does that happen? It happens during the diastole, like during the ventricular diastole. So during the ventricular relaxation, that's why the pressure in the right atrium kind of equals the end diastolic volume. So it's the amount of blood that's there during the atrial diastole or ventricular diastole. So it's the amount that accumulates in that atrium or in that ventricle. So it's the end diastolic volume. So that's for the x-axis, okay? But for the y-axis, it talks about two variables. In this graph, we're going to talk about the cardiac output. So the cardiac output is basically the ability of the heart to pump how much blood. So that depends, of course, on the heart rate, on the contractility, on what the heart can do in order to get as much blood out. So that's for one that we're going to talk about here. And sometimes in the other graph, it would represent the venous return. So the venous return is, just as we said, the blood coming back to the heart through the superior vena cava and through the inferior vena cava. Well, as we said, the cardiac output is the two main arteries that are coming out of the heart into the aorta and the pulmonary artery. So that's the cardiac output, okay? Now, what we have in one is that we're going to take, okay, so what we have, there's another point here called the mean systemic pressure. It's a theoretical point. It's not real. It doesn't happen in real life, but it's only for easier understanding of the process. So it's this mean systemic pressure equals to the pressure in the right atrium when the venous return is 0. So this is how much pressure in the right atrium if there is no blood going back to it, and this does not happen in real life. So what we have here is this is normal. The graph one that have this red curve and this blue curve without any additions, without any changes, is just the normal resting person who does not have medication, who does not have heart failure or any kind of disease. So in normal conditions, the cross section between these two curves, the one that represents the contractility and the heart function, basically like the cardiac function, and the other one that is representing the vascular function, about how much the vessel are containing blood within them. So the cross section between these two graphs is just the normal point. This is in a normal condition, in a normal person who does not have anything as a problem. So now we're going to do some changes to that person, or that person is going to develop some diseases that going to affect any of those curves, okay, whether it's the cardiac function curve or whether it's the vascular function curve. So if we say, let's say, increase or decrease the inotropy. So we know that the inotropy is the contractility of the heart. So if we change the contractility, whether we increase it or decrease it, that means we are basically playing or changing the ability of the heart to contract and pump as much blood as a cardiac output, pump blood to the outside of it. So that will also, of course, do changes in the stroke volume. Somehow the stroke volume equals to the cardiac output. And if we are changing the contractility, we're changing the cardiac output. And of course, the cardiac output is just going to go through all of the body and then go back to the superior vena cava and inferior vena cava. So if we're changing the cardiac output, we are by time changing the venous return. We're changing how much goes out, so we're changing how much comes in the heart again. So of course, because we're changing the venous return, then we are definitely changing the right atrial pressure over here as well. So for example, if we're giving a patient acetylcholine or dobutamine or milrinone or digoxin, or if he's just normal person who's doing some exercise, so we are increasing the contractility, that is the inotropy of the heart. So the inotropy of the heart is just affecting the heart itself. It does not affect the vessels. So if we take a look here, we are just making this part of the heart, all of it, I mean actually, to contract harder. So by contracting harder, we are not making the vessels contract harder. We're just making the heart do so. That's why the only thing that is going to change is the cardiac function, okay? We're not playing anything with the vascular function curve. We're not changing anything with the vessels. We're only playing or changing the cardiac function curve. So that's why if we are increasing the inotropy, so of course the cardiac function is just going to increase upward. So this is only a change in the cardiac function. While if we increase the inotropy, as in patient who has a heart failure, so basically their heart is failing, their left ventricle and right ventricles are losing the ability to contract hard, so they reduce their contraction, and if they do so, that means their cardiac function curve is going down. But does heart failure change anything with the vessels? No, because it's not changing anything with the vessels. That means the vascular function curve is not going to change as well. So our only thing that is changing with the heart failure, and also in addition to the heart failure, someone who's having a narcotics overdose or having a sympathetic inhibition, that both of these, they decrease the cardiac function curve. So now, as we can see, for changing the inotropy, that means we're only changing the cardiac function curve, and it's either going up or going down, while the vascular function curve stays as it is without any kind of change. So that's for graph A. If we go to the graph B, we have the same x-axis and the same y-axis. And we have the right atrial pressure, as we said, and now we're going to talk about the venous return. So it's the blue line. So for the blue line, if we are changing the amounts of blood in the vessels, so for example, changing the circulating volume. Circulating volume means the blood within the vessels, like aorta, pulmonary artery, or just superior vena cava, inferior vena cava, stuff like these. So it will definitely change the right atrial pressure and the stroke volume, and it would lead to changes in cardiac output. That's so quite easy if you think about it here. If we are changing how much blood is contained within these vessels, then it will definitely change how much of the blood going into the right atrium, and of course changing the pressure of the right atrium, and also that blood is going to move into the ventricles, and then it will go out as a cardiac output. That's why the cardiac output is in such cases is also going to change depending on how much venous return is going to the heart. So of course the arterial blood that is going out of the heart is going to change as well. So if we have a fluid infusion, if there is a patient who is severely dehydrated, comes to the emergency department, and we try to give them IV fluid, or if we increase the sympathetic activity, or if someone is who has a arteriovenous shunt, all of these factors will increase the amount of blood in the veins, or it will increase the venous tone as in sympathetic activity. So that will increase the sympathetic tone. That would lead the venous curve, venous function, actually vascular function curve is the one that is going to change, because we are not doing anything related to the cardiac contractility or cardiac heart rate. We're not playing or changing any of that at all. All what we're doing is that we are increasing either the blood volume in the vessels, or we are just increasing the vessels tone. So basically we're dealing only with the vessels. So the only change here is happening regarding the vascular function curve. So it's either going up or going down, while the cardiac venous return is just fine. So for if it goes down, that happens in cases like acute hemorrhage, if we are losing blood, or if we have spinal anesthesia. Both of these will decrease the vascular function curve because they reduce the amount of the blood contained within these vessels. So that's why the volume goes down. I mean, the vascular function curve would go down. So that's the change happening in the vascular venous curve. So in case 3, in graph 3, we have a change in the total peripheral resistance. So what we know is that the total peripheral resistance is mainly dominated by the arterioles, and they are the smallest part of the arteries. So let's say that the total peripheral resistance increases. That means the the resistance that the heart needs to pump against increases. So if it increases over here, there is an area of oxygen exchange and nutrients exchange. And it increases its total peripheral resistance. That means that the heart needs to pump harder to get through that total peripheral resistance, and that means the cardiac output reduces because the total peripheral resistance is attached to the aorta, and the aorta is attached to the heart. So it reduces the cardiac output because we have an increase in the total peripheral resistance. And of course, if we are reducing the cardiac output, then we are reducing the venous return as well. So that's if we are using something like vasopressors, okay? So let's say there is a normal vessel over here with specific width, and blood is going through, and we use the vasopressors that would cause this vessel to go smaller and just press it. Then it's harder for the blood to flow through it and go out of it. So what is changing here, as we said, is the cardiac output and also the vascular function curve. So we can see if we increase the total peripheral resistance over here, then we're pulling the venous function curve downwards, and as well pulling the cardiac function curve as well downward. So the cross section between these two lines is going to go down. So the normal is going to get down over here. So this is the normal point that we talked about earlier. Now it's going to change and go to a lower place, because this is the only way that changes happen to both graphs, to both curves, the cardiac and the vascular, because total peripheral resistance affects both. While that's if we are increasing the total peripheral resistance. Sometimes in exercise and arteriovenous shunts, we are decreasing this total peripheral resistance. So we, of course, if the resistance over here goes down instead of going up, so that means it's easier for the heart to pump more, so there will be an increase in the cardiac output. So the heart does not struggle anymore, and because the total peripheral resistance is reduced, so the heart can pump easily and nicely, and everything is fine. So the cardiac output goes up because now the heart can pump much more blood. So, and the cardiac output, of course, is going to end up somehow as a venous return, so we are changing that as well. So that's why also the decrease in the total peripheral resistance is going to affect both of these curves. Like, it's not going to only affect the heart, and it's not going to only affect the vascular, it affects both. That's why if we decrease the total peripheral resistance, then the cardiac function curve is going up. The cardiac function curve is going up, and at the same time the vascular function curve is going up as well. So their cross section now becomes this point. So we are basically changing the two